All right. Well, welcome everyone to Tuesday nights or Tuesday afternoons, the lecture series here. I'm Brett Klein with Eisenhower Health, and I have the pleasure tonight to work again with Dr. Christopher Hicks. And he's got a great topic for this evening of prevention and treatment of female incontinence and pelvic organ prolapse. And as I let people into the room, just a couple of housekeeping pieces. This is being recorded, as you well know. And then we have currently your mic and your video turned off so that we don't have that issue going forward. We will feel free to use the chat feature as we go along and ask any questions, and then we'll be sure to get all those answered. And at the end, we will also open it up for live Q&A with the doctor. So if you want to hold those till then, we will get going. But with that, I'm going to turn it over directly to Dr. Hicks, and he'll get moving. Dr. Hicks, that's all yours, sir.
Hi, welcome everybody. Thank you all for joining. I picked a topic today to talk about that is something that a significant amount of the population here in the Valley is frequently dealing with, and I feel like is underaddressed. So about 60% of postmenopausal women deal with some sort of either pelvic organ prolapse or incontinence of some variation. So today I'd really like to touch on both topics per se. We'll briefly talk about the presentation as well as modalities of management and ways that hopefully we can be proactive in preventing some of these issues in the future. So prevention and treatment of female incontinence and pelvic organ prolapse. There we go. Okay, I apologize. So what is urinary incontinence? So when we're thinking about urinary incontinence, this is the involuntary leakage of urine, okay? Sometimes there might be a sensation where you feel the need to go to the bathroom, but may not make it in time. There may be particular activities that exacerbate symptoms of incontinence. And then for some individuals, there may be no warning signs whatsoever. So the incidence approaches approximately 50% of adult women, and over 70% of women over the age of 60 have urinary incontinence, okay? And when we're thinking about the different types, I briefly just talked about a couple of the variations of it, but stress incontinence is the type of incontinence that patients will typically come into me and they'll endorse symptoms of usually small volume of urine leakage, typically with coughing, laughing, sneezing. Occasionally, they'll be talking about when they're running, they'll have to wear a pad due to small volume amounts of leakage. If anybody's using a trampoline, that's another exacerbating factor. And occasionally when lifting objects, you valsalva and inevitably may experience a small volume of leakage as well. So urgency is when we were speaking about sensation to go to the bathroom, but we don't make it in time. Okay, so there's a topic out there called overactive bladder. Overactive bladder is very consistent with being the modality that essentially leads to urge incontinence, which is feeling that urgency to go to the bathroom, but you cannot make it there in time. And then unfortunately, there's some individuals that experience both stress and urge incontinence. So these patients, they have leakage when they cough, laugh, and sneeze, and they also have the sensation to go to the bathroom and may not make it there in time. And overflow incontinence is a very difficult type of incontinence to manage. And these may be patients who don't even know or have any sensation whatsoever that they need to utilize the bathroom. Typically, these patients might have spinal cord injuries, possibly uncontrolled, diabetic neuropathy per se, things that are neurologically mediated where they don't get that sensation. So I have a little picture here off to the right, which is essentially going over some of those symptoms that we talk about. So anything that causes you to have leakage where you're lifting an object, or maybe you don't make it to the bathroom in the top right-hand corner, that would be more of an urge incontinence. Occasionally I'll have patients who tell me they wake up in the middle of the night without any sensation and they have wet the bed. And all too frequently, patients also have symptoms where they're going frequently every night. So we'll get into that a little bit more here. So toilet mapping. This is one of the things I talk to patients about when they come in endorsing incontinence. And toilet mapping is essentially when you find yourself going into a facility, let's just say it's a concert over at Acrisure Arena, and the first thought that you have is, where is the bathroom? And that is classic toilet mapping. You know that at some point you're going to have that urgency episode and need to make it to the bathroom. Toilet mapping is more frequently seen with urgent incontinent patients because you get that sensation and you know you need to get there. And so these patients typically know where these bathrooms are in whatever facility or event that they might be attending to. So risk factors. So risk factors, age is obviously an important risk factor. The older our patients are, the more frequently we encounter incontinence. But I will be honest with you, I have patients that are in their 20s and 30s that have stress incontinence and urgent incontinence. It just happens to be as a patient ages throughout life, incontinence becomes more frequently encountered. Females tend to encounter incontinence more frequently than males. Obesity does play a risk factor into patients' incontinent issues. And particularly, we find that obesity increases the risk of stress incontinence. That's that leakage with coughing, laughing, sneezing. Parity is the term essentially talking about how many births you've had per se. So vaginal births and cesarean deliveries are both associated with incontinence, although vaginal deliveries more so than cesarean deliveries. Ethnicity is also a factor. People of white ethnicity typically tend to have more incontinent episodes than others. And as we briefly touched about medical conditions, in particularly uncontrolled diabetes can cause significant issues in regards to how the nerves behave. So incontinence is encountered in diabetes, any neurological issues, maybe possibly multiple sclerosis. People who've had lower back injuries that may have disruptions in how their nerves are behaving. Typically, medical conditions are all neurologically mediated. Now, occasionally, patients can also be on medications, which can increase the risk of having incontinent episodes. For instance, the good old water pill that people discuss being on, or hydrochlorothiazide, is a diuretic that causes you to have to urinate more frequently. And when this occurs, you might have more incontinent episodes. So, stress urinary incontinence. I want you to think of this. Stress urinary incontinence is essentially being a weakness in the ligament that's under the urethra. So you'll look at this bladder over here, and on the right-hand side, I have a picture for it. And you'll see a ligament that goes under the actual urethra, which is labeled here. And what happens is when you have stress urinary incontinence, that ligament is per se a little looser than we would want it to be, and the urethra is hypermobile. Okay, and that's something that we often as practitioners talk about in our exam, is whether the patient has a hypermobile urethra. Often I'll ask patients to cough very strongly, and we will see the urethra almost bounce there 30 degrees from the horizon. And that gives a good indication that the patient has a hypermobile urethra. With that cough test, we might also notice leakage there in the office. Okay. So loss of urine with coughing. So smokers are going to be more prone to these particular types of incontinence because smoking obviously causes the patient to cough more frequently. Laughing is another exacerbating factor because these are all causing increased pressure. And when that pressure happens, it's pushing there on the bladder. You'll notice that diagram, you see that increased pressure arrow. All of these are increasing or causing a Valsalva per se to push down on the bladder. And when you push down on the bladder, that urethra doesn't have enough tone under it, and it allows a little bit of leakage. And these are small volume amounts of leakage. Other modalities we encounter this with is sneezing. Often patients will talk about with weightlifting, they will notice some leakage that does occur. And sometimes even with sexual activity. Urge incontinence. So urge incontinence was that modality we talked about where you have that sensation and you can't make it to the bathroom. Volume is variable. We do tend to notice that volume with urge incontinence tends to be a little bit larger than stress incontinence. And as I previously touched on, overactive bladder, which overactive bladder is having to utilize the bathroom much more frequently. When you are having that urgency to go to the bathroom and you keep having to go to the bathroom, keep having to go to the bathroom, that's overactive bladder. when you start to have leakage and you don't make it to the bathroom, that's urgent incontinence. And we do find that this is a modality that has a high association with our older populations, and particularly our menopausal patients. So mixed and overflow, we briefly touched on this before. Mixed is a combination of stress and urgent incontinence. So the patient will have leakage with cough, laugh, sneeze, as well as urgency episodes. Very difficult one to manage as well, because you might fix the stress urinary incontinence, possibly with a surgical procedure or conservative management, and then you find yourself having to add medication on just to help out with some of those urgency episodes. So overflow incontinence, we also briefly touched on as well. These are some of those neurologically mediated issues, or bladder outlet obstruction as well. So evaluation. So the first thing I do when a patient comes into me is I touch on prolapse and incontinence all in one shot, because I feel like they very much are interconnected, and a lot of the risk factors for one modality are also affiliated with prolapse. So evaluation, I start off by asking some questions in regards to what are the exacerbating factors? Are there any urgency episodes? We take a look at the medications. We did talk about medications that help with hypertension, that water or diuretic medication that causes you to pull some of that extra fluid off. Well, that causes you to frequently urinate, and you might have a little bit more leakage when you're on those medications. There's a multitude of different medications which may also interfere with how the bladder is working as well. And these two can increase episodes of incontinence. So I do have a questionnaire here off to the right-hand side, so you can briefly read through it. A lot of these questions I just ask while I'm in the encounter with the patient. And it kind of helps to assess, are we dealing with just one type of incontinence, a mixture of two different types of incontinence? And then often I'll ask patients to keep a diary as well. That'll help me out with triggering some of these episodes and what might be exacerbating some of her symptoms. So systemic symptoms, is there a UTI present? So UTI symptoms are typically frequency, burning with urination. There might be a foul odor to the urine. There might be cloudiness to the urine. UTIs should be treated with antibiotics. If they're not treated, they do have a higher propensity to causing an ascending infection, where they can eventually affect the kidneys per se. And then often I ask patients, with your leakage, how much is this altering your quality of life? Do you find it's inhibiting your interactions with your spouse? Do you find it's inhibiting your ability to be active? Maybe you don't find they're able to go play pickleball or go work out anymore because you're leaking so frequently, or possibly maybe you're having vulvar irritation or vaginal irritation because of some of the sanitary products that you're routinely having to utilize because of the leakage. So quality of life is very important. And as we age throughout life, quality of life is truly what it comes down to. So if it's affecting your quality of life, you definitely want to do something about it. Physical exam. The physical exam is very important to me. So the physical exam, when we're dealing with incontinence, is what we briefly discussed before. I'm going to ask the patient to cough. And usually when I describe it to patients, I say, give me that big smoker's cough like you hear in the restaurant. I want a big cough. And hopefully I'll see a little bit of leakage on exam, but I also want to see that urethra essentially bounce from the horizon over 30 degrees. And that's going to give me a good idea about how supportive the ligament is under the urethra. So we briefly discussed voiding diaries. So voiding diaries are a way that the patient can identify triggers that might result in possible incontinent episodes or urgency episodes. And typically, I do tell patients that a lot of the great things in life, unfortunately, are irritants to the bladder. And, I've put a couple of them here on the slide. So obviously, the amount of water we drink is going to influence how frequently you have to use the bathroom. Here in the summer months, we're having to drink a lot of water, so you frequently will be urinating. Now you'll see a coffee cup up there, and unfortunately, coffee is an irritant to the bladder. I love coffee, but I know for myself too that it's going to cause me to have to use the bathroom more frequently. You see a glass of red wine, alcohol in red wine, carbonated beverages, chocolate, These are all triggers which cause overactive bladder symptoms. So, like I said before, a lot of the great things in life, unfortunately, do cause some of these exacerbating symptoms of incontinence. So, back to the voiding diary. The voiding diary is very helpful. It'll allow me to kind of identify the volume of urine that is actually being leaked out. Was there any inciting factors? Um, what time of day was it? Is it just nocturnal or in the middle of the night that we're having these incontinent episodes? So stress incontinence, we have preventative strategies available. So when I talk about prolapse and incontinence with patients, first off, when a patient comes into me for an annual visit, I feel like as a gynecologist, it's really important that a patient understands that pelvic health, just like our heart health, is something that should have a priority in life. The pelvic floor is important for urinary incontinence, fecal incontinence, and prolapse. So if we can prevent these things from happening, we should do it. Okay. So when we're talking about preventative strategies, we're talking about if we have an individual who's overweight or obese, weight loss will help decrease some of these episodes. Dietary modifications. So we're talking about avoiding some of those triggers, that chocolate, that red wine, that carbonated beverage, that coffee. Decreasing how much of that we're taking in on a daily basis will help hopefully decrease some of these symptoms. Treating back up to smoking. Smoking cessation is healthy for a multitude of reasons. And particularly stopping smoking actually helps out dramatically with decreasing urge and stress incontinence. Treating constipation is very important in regards to both an incontinence perspective as well as a prolapse perspective as well. And we'll get into that a little bit later. Now, Kegel exercises. This is something I ask every time I see a patient for an annual visit. How often are we doing our Kegel exercises? And all too frequently, most patients will tell me, I'm not. And so I really like to talk to patients about prevention. So we want to prevent these things from happening. And when we do have these events happening, we still want to use Kegel exercises. It's not too late to use them, but we need to be using them effectively. Okay. And when we talk about effectively, we talk about routinely utilizing them. You're going to go out there every day to engage in cardiovascular activity, help out with heart health. You want to do the same thing for your pelvic floor. So when we're talking about Kegel exercises, we're talking about 8 to 12 contractions. And if you go onto YouTube, you'll see a multitude of different types of Kegel exercises. Sitting Kegels tend to be the ones that have the better compliance because patients can do them every day. And you'll see a stoplight up there. And that's part of my counseling with a patient is every day you're going to get in a car. Every day you're probably going to hit a red light. And unfortunately, these red lights tend to be a little bit longer this time of year. And that's the perfect time for you to engage in Kegel exercises. Nobody's got to know what you're doing, okay? And if you're able to get a couple Kegel exercises in just at that red light and you've accumulated them throughout the day, you're going to find yourself, working out that pelvic floor quite well. So you want to do about 8 to 12 of those contractions 3 times throughout the day. And I'm willing to bet most people here are probably going to hit 3 red lights throughout the day. Urge incontinence. So how do we treat urge incontinence? So urge incontinence, can be treated with medication. I find frequently this is where a lot of patients tend to start off. I also think dietary modifications are very important, and I wish I probably would have put that up at the top of the slide with stars on it. So avoiding some of those triggers that we previously talked about is very important for overactive bladder as well as urge incontinence. Now, when we're talking about treatment, we're talking about what we have here is anticholinergic medications, and these are typically first line. Now, we use them very frequently. Now, over the age of 65, I tend not to use these medications because there is some data that shows that it does affect cognitive issues. So in some of my patients who baseline have cognitive issues, these should not be utilized. And over the age of 65, I tend to try and avoid them and utilize the 2 other medications you see below. Mirabegron and Virabegron. That is a typo. That should be Virabegron. These are both They work on the beta receptors at the bladder level. They have a little less side effect profile as compared to the anticholinergics. Now, when we're thinking about anticholinergic medications, something like Vesicare might sound familiar. That medication does have significant side effects, which some patients find significantly bothersome. So we're talking about dry mouth, dry eyes, possibly worsening of constipation. And constipation is something that is frequently encountered in patients as they age because the GI motility tends to slow down throughout life. And so if we're taking a medication that also impacts that, it's not helpful. So mirabegron and virabegron are two modalities that have a little bit better side effect profile. Biggest contraindications to utilizing these medications are if you have uncontrolled hypertension or high blood pressure. So stress urinary incontinence treatment. So we did talk about some of those conservative management options, okay? So utilizing Kegels is a way to hopefully prevent some of those worsening symptoms or preventing them from ever developing at all. Pelvic floor therapy is underutilized in the US, and I feel like it's something that I hope changes in the future because there are countries out there in particular, France, when you have a baby, you are immediately engaged into pelvic floor physical therapy. Okay. And some patients come to me when I suggest pelvic floor physical therapy and they say, well, I already do my Kegel exercises. And I try to encourage that you should think of pelvic floor therapy as not just Kegel exercises. I call it Kegel exercises on steroids. So there are no steroids involved in this treatment, but essentially we have some lovely pelvic floor physical therapists here at Eisenhower, and they're specifically trained in helping us with the issues of the pelvic floor. And what they'll do is they'll essentially establish where your defects are, what we're trying to treat, and they're going to tailor up a treatment plan to hopefully alleviate and decrease the symptomatology of whatever symptoms that you have pelvic floor engaged for, whether it be for stress incontinence or prolapse. So bladder training is essentially a means of utilizing the bathroom more frequently. So this is going to be more effective in patients who are drinking very frequently throughout the day. You want to make sure that you're voiding frequently and keeping the volumes in the bladder low. Patients on diuretics, you're going to want to have timed voiding, which is, every such and such time I go to the bathroom, I'm making sure and empty my bladder. Topical vaginal estrogen, this is also known as estrace or Premarin, topical vaginal hormonal creams, essentially. So they are very effective at helping change the mucosa around the vagina with patients who have vaginal atrophy or pain with intercourse. They're also very helpful for patients who have stress urinary incontinence. And we do find that it can be a very effective tool. Now, surgery is the last modality out there. I tend to tell patients if you can avoid surgery, you should. Now, I myself am a surgeon here at Eisenhower, but I really like to have patients avoid the OR if they can. Unfortunately, there are particular scenarios which surgery may be the best option for the patient. So if you look over here to the right, you're going to see a pelvis, okay? And that big ball that you see that's gray, that's going to symbolize the bladder there. And you have a little gray tube that's coming out. And you'll see that little arc per se that is present there is stimulating what we call a sling. So a sling is a little piece of mesh. Now mesh has changed over the years, and some patients might say to me, well, I thought all mesh was off the market. And in some regards, it has been taken off the market for particular modalities, in particularly when we're doing vaginal repairs for prolapse. We do not use it for intravaginal repairs. We do use it for stress urinary incontinence, as well as for a procedure called a sacrocolpopexy, which we'll get into a little bit later. So when we're talking about a midurethral sling, it is a small piece of mesh. There are a multitude of ways to place this mesh. There is a transobturator approach, which is one of the older techniques, but very successful as well. Those patients might have a little bit more groin discomfort with the TOT or the transobturator mechanism of utilizing that sling placement. There is a retropubic approach, and that is essentially coming from the abdomen and coming out through an incision right under the bladder. And there's what we call them mini slings. And these are newer slings. I use them frequently. The patients tend to have minimal pain. In fact, I have to remind patients after the surgery, you just had surgery, please take it easy because patients tend to do so very well with these slings. And it's a single incision. So it's a single incision under the urethra. There's no incisions in the groin, no incisions on the abdomen. And that's what differentiates this type of sling as opposed to other sling modalities out there. So overactive bladder and urge incontinence. Treatment, we talked about Kegel exercises, utilizing them frequently, 3 times a day, 8 to 12 of them at each session. Adjustment of medications, which may be causing exacerbation of overactive bladder or urge incontinence, possibly some of those diuretic medications. Dietary modifications, decreasing some of those lovely things that we like to indulge in life. Lifestyle adjustments. Medical management is some of those medications we talked about, like an anticholinergic or mirabegron or virabegron, as well as some other medications that are employed by some of my friends here at Eisenhower. So some of our urologists here can utilize PTNS, which is posterior tibial nerve stimulation. It's a method where we stimulate a nerve in the back of the leg that helps out with some of these symptoms, as well as Botox. And some patients on here will be thinking, Botox in the bladder? But I will be honest with you, it's a very effective mechanism for treating overactive bladder as well as urge incontinence. And that Botox is essentially the surgical option that I'm referring to. So pelvic organ prolapse, very, very, very important part of our talk today. Okay, and this does go hand in hand with incontinence. Often a lot of patients who have pelvic organ prolapse have coexisting stress or urge incontinence affiliated with it. And often patients, when they have correction of their pelvic organ prolapse, may also encounter incontinent episodes secondary to that correction. So let's get into this a little bit more. So what's prolapse? Prolapse is a weakness in the structural integrity of the pelvic support, and we're going to get into that next here, okay? So the incidence of pelvic organ prolapse is very frequent. Like I said, it's approximately 60% of our postmenopausal patients are experiencing pelvic organ prolapse of some sort. And unfortunately, I think that statistic is probably underestimated because a lot of patients don't realize they have prolapse until they become significantly symptomatic. Okay. Now, yes, it should be something that's recognized on exam. And whether or not you're having routine gynecological exams is the other issue. I have very frequently seen patients who've said, I haven't seen a gynecologist in 20 or 30 years because I was told at menopause, I never need to see you again. And, it sounds great. You never have to see another doctor again, but it is important that somebody does evaluate that we're not having any issues in regards to your vulvar health or the external part of the vagina, as well as any coexisting prolapse or incontinence you might be encountering, as well as other issues that we need to talk about in regards to, do you have any symptoms in regards to endometrial or ovarian cancer pathologies that we should be concerned with? And are we continuing to utilize pap smears? So step 1, talk to your doctor. So that doctor should hopefully assess whether you have any symptoms. And when we're talking about symptoms, patients come into me and they'll talk about possibly pelvic pressure that's there. And it might be intermittent, it might be persistent. They might talk about a vaginal bulge or possibly there's some tissue that protrudes in the vagina. And frequently I'll have patients say, I'm frequently having to push something into the vagina that's coming out, and I'm really not sure what it is. And some patients even refer to it as a hernia per se. Occasionally, patients will report lower back pain. And as we previously talked about, some urinary dysfunctions. So we might have symptoms of overactive bladder, urge incontinence, or that stress incontinence, that leaking with coughing, lapping, sneezing. Defecatory dysfunction. So patients might even come in and they say, I have significant constipation. It's gotten to the point now where I actually have to put a finger in the vagina to fully evacuate my bowels. And at that point, that's called splinting. That's something that is alarming because that means the prolapse is significantly worse. Sexual dysfunction. So prolapse can unfortunately result in discomfort with intercourse. You have to remember that prolapse in itself is a weakness in the pelvic support. And we're going to talk about this on an upcoming slide here. So here's that slide we're talking about. So when we think about pelvic organ prolapse, I want us to think of the vagina as a cylinder per se, and at the end of that cylinder is the external opening, and at the other end of that cylinder is where your cervix and uterus are. On the top part of that cylinder is where your bladder is, and I'm gonna have a little pointer here, hopefully you can understand that. So here's our cylinder here, okay? This is the external opening, that's the vagina. This is our bladder here, and then all the way internally, here's your cervix, and this is the uterus. Behind the vagina is where the rectum is. Okay. So you can see with a patient who has significant constipation, there's a significant amount of stool which accumulates in here, and the patient is having to push a little bit harder, which causes protrusion into the vagina or something called a rectocele. Okay. So rectocele is over here on the backside. Okay. So this is protrusion into the vagina on the backside. And typically, if you're looking at the patient at 6 o'clock, you will notice protrusion of the vaginal tissue out of the base of the vagina per se. Cystoceles are quite frequently encountered, especially when patients have had some vaginal births. Patients may incidentally be noted to have a cystocele and be entirely asymptomatic, but that's in the anterior compartment here. So anterior compartment on the front side of the vagina, protrusion of the bladder. So this area has become weakened and it allows the bladder to drop into the vagina. Uterine prolapse. So I want you to think of uterine prolapse is also referred to as apical prolapse. So the uterus here, where's my pointer? The uterus here, it doesn't have it visualized, but the uterus has some ligaments here that support it. Okay, so a lot of times these are what are called your uterus sacral and your cardinal ligaments here. And these help keep the uterus inside the abdominal cavity. Now, occasionally, the uterus will come down, and this is called uterine prolapse or apical descensus. All too frequently, when patients have uterine prolapse, there is coexisting cystocele present and possibly a rectocele, but all too frequently, there is a cystocele. And the reason that is because I want you to think the bladder sits on top of the uterus like a saddle on a horse. So if the horse is coming down, that saddle, which is the bladder, is coming down with it. So there's uterovaginal prolapse as well as a cystocele present. Risk factors for prolapse. So increasing incidence with increasing parity. And parity is that term we talked about, the amount of deliveries the patient has experienced. So the more deliveries the patient experiences, the more frequently we do encounter prolapse. Weight of the infant. So when patients come into me and they say, I had a delivery of a 10 or 11 pound child. Well, before I examine the patient, the next words out of my mouth are, please tell me you're doing your Kegel exercises. Those patients tend to be significantly bothered by prolapse at some point in life. And all too frequently, those larger infants might have required some sort of operative delivery. And so when we're talking about operative delivery, were there forceps used to deliver the baby? Was there a vacuum used to deliver the baby? Those particular modalities do increase the risk of having prolapse per se. As I previously discussed, age. So as we age in life, increased risk for prolapse, just like incontinence. Obesity, as it affected stress urinary incontinence, it too does find that it affects prolapse significantly. Chronic cough and constipation. So those are two modalities which increase your intra-abdominal pressure, put a little bit more pressure on your internal organs, which cause a little bit more protrusion. So chronic cough, you're going to think you're going to have more risk of prolapse, possibly some stress incontinence. Constipation, you're having to push a little bit harder when you're totally evacuating the stool, and this is going to leave patients more prone to develop something like a rectocele. Connective tissue disorders, so these are patients that they may have tissue that is not organized like a typical individual, and they're more prone to having stretchiness of that tissue per se, and that allows prolapse to occur more frequently. And we do notice that there is a significant amount of individuals who have a pretty significant family history. So patients may say, yeah, my mom, she had a hysterectomy when she was 55. It was related to possibly maybe a vaginal birth or not. And now that patient too also has prolapse at an earlier age as well. So there is a significant family history. So how bad is it? Like we said, quality of life is what it comes down to. So I might notice these findings on exam, and I'll ask the patient about symptoms that they may or may not be experiencing. And once we start engaging into symptoms, typically patients also start to tell me a little bit more about, you know what, there has been this symptom and this symptom and this, and you know what, it has been starting to affect my quality of life. I just didn't realize there was anything I could do about it. I just thought this was just part of aging. And so I really want patients to walk away today and realize this is not something that you have to deal with. There's a lot of different modalities to help you out there, and they don't all involve surgical modalities. There's a lot of conservative ways to manage these issues. So does it limit your daily activities? Are you able to get out and exercise? Can you go play that pickleball? Can you go shopping with your girlfriends without having significant pelvic discomfort or heaviness within the vagina? We touched on the exercise part, but has your sex life been altered due to prolapse? Is there pain with intercourse? So management options. So expectant management can be employed. I tend really not to engage in expectant management because I'm all about being proactive. If we know there's a problem or we know the patient has a risk factor for a problem, we certainly should be doing things to prevent the occurrence of this happening. Okay. We talk about conservative management of prolapse. We frequently are referring to pessaries, which we'll get into a little bit more. And pelvic floor physical therapy, just like it's very effective for stress urinary incontinence, it too is very effective for prolapse as well. And then topical HRT, this is also that estrase that we previously touched on. This is not something that goes systemic. This is a cream that we place in the vagina. And typically you're utilizing it every night for 2 weeks. And then you go into what we call maintenance therapy, which is utilizing that cream twice a week. And then when we're talking about surgical options, there's a multitude of them. I'm going to hopefully get into that slide here momentarily. So surgical options. So you might have heard of the layman's term of, I had a lift done, or my girlfriend had a lift done. And when we're talking about a lift, really that is an anterior repair, or anterior colporrhaphy is the actual term that we use as physicians. And essentially what we're doing is we're plicating the vagina and we're tightening up the tissue there to provide support to prevent that bladder from dropping. We do the same thing on the backside of the uterus, and that's called a posterior repair, okay, or a posterior colporrhaphy. And it also encompasses that same modality of tightening this. Now, I want you to kind of ignore the sacrocolpopexy. We're going to talk about that in a second. But essentially, we're plicating or tightening these areas on the anterior or posterior, depending upon what degree of prolapse a patient has. Now, I want you to realize that prolapse comes in multiple flavors. It might be strictly just related to the bladder. It might be the bladder with the rectocele or the posterior aspect of the vagina, or where the rectum protrudes into the vagina. It might be just apical descent, is just the uterus coming down without anterior defect. It might be anterior and uterine. It might be all three of them, or procedentia, which is complete expulsion of the organs. Okay. So sacrocolpopexy is what I have the slide up here for. You'll notice the mesh that we have here placed. This is what we call a Y-shaped mesh. Essentially, the way this procedure is performed, a hysterectomy is performed. Whether or not the cervix is left behind is entirely based upon the patient. But we do either take the cervix or we leave the cervix, and then we attach a mesh on the anterior portion of the vagina. We attach a mesh on the posterior portion of the vagina, and then we anchor that to the sacrum. So we call that a sacrocolpopexy. And typically these procedures are all done laparoscopically. The anterior posterior repair, those are vaginal repairs that we do, and we find a significant success with those. Colpoclesis. Now, this is a procedure that we don't use frequently enough. I feel like it's very, very important to talk about it with patients. And essentially, it is a procedure where We utilize this procedure, by the way, for patients that might have significant comorbidities, or maybe they're not a very good surgical candidate for very involved surgery. And it's a very basic surgery where essentially, I'm going to take the pointer here, we are stripping the epithelium in the vagina down, okay, and we're suturing the vagina closed per se. And some patients look at me and they say, "You want to suture the vagina closed?" Well, it can be very effective for the right individual. And patients who, are later in life and they are no longer sexually active, that might be a good alternative for them. But that is something that I tell the patient, you really have to think about this option long term before you engage in it, because you cannot reverse it very well. But it can be very effective. I've had a patient come in who no longer was sexually active with her partner. She had colpocesis done, and she said, this saved my marriage, because the quality of life I had from my prolapse was just affecting my relationship. And she underwent the colpocesis, and she said, it's been life changing. So it seems very extreme, but it's the right procedure for the right individual. Definitely not something we routinely use, but potentially utilized for the right individual. So what are we looking at here? So these are a bunch of pessaries, okay? Pessaries come in multiple shapes and sizes, and these are just a small amount of the pessaries that we have here. When we're utilizing pessaries, when I bring a patient in and they've elected to utilize a pessary, I say, this visit is not going to be a short visit. And what we're going to do is we're going to do some measurements. And really, what we want to do is find the best pessary for you that reduces your prolapse, but doesn't cause discomfort or pain, okay? And when that pessary gets placed, you will know it's there for 40 to 72 hours, but it shouldn't cause discomfort, and it surely should be reducing your prolapse. And then after I find the right fit for the patient, I really encourage the patient to walk around the office, take time, even go walk around in the parking lot, do the things you would normally do. Go take some practice golf swings outside, really feel that that pessary is a good fit for you. Now, if that pessary is falling out when the patient goes in voids, obviously not the right fit for the patient. And we're going to work to find the right fit and the right model that we should be utilizing on that patient. And that's going to be dependent upon a multitude of factors. So some pessaries up at the top here are good for cystoceles, or possibly maybe some stress urinary incontinence with the cystoceles. So some of those knobs you see up at the top, let's get that pointed. This is a knob with a ring here, knob and a ring. Those are going to be helpful for reducing prolapse, as well as that knob putting a little bit of pressure under the urethra, and that's going to help with some of that leakage when you cough, laugh, and sneeze. We have a dish here down in the left-hand corner. We have a donut here on the right. We have a flexible cube. Now, this is a fantastic pessary for the right individual. Unfortunately, it's one that the patient has to take in and out of the vagina every night. It can be cumbersome for patients, especially patients that have joint mobility issues, and removal can be difficult. And then a very successful one here that we use quite frequently is a Gellhorn. Now, Gellhorns come in short stem, they come in long stem, they come in rigid, they come in flexible, and these are just different characteristics of that pessary. These are great for the worst types of prolapse. It can be very effective for stage 4 prolapse or complete prosedentia, which means all organs are out. So how does it work here? Okay, so what we're looking at here is a ring, okay? It sits behind the pubic symphysis, okay? And this is the pubic symphysis, this is the bladder, this is the vagina, and this is the ring here. So the way it sits here, it keeps everything up here, and it prevents that apical descensus here. Very effective for people who have prolapse, especially cystoceles. Maybe a grade 2 or 3 cystocele would be a good choice. So POP is the terminology we use for prolapse. Okay, pelvic organ prolapse is POP. So the ways to prevent it are back to our Kegel exercises. So just like you work out your heart, you should really be utilizing Kegels to help work out your pelvic floor, prevent prolapse before it happens. And if we do have symptoms of prolapse, there's things we can do about it. Okay, I don't want patients to come in and say, I've been talking to my provider about this for years, and nobody's told me that there's options for me. And I will tell you, there's many options, and hopefully we can help get you a quality of life back. So if anybody has any concerns, I have left the contact there for you to call our office. and make an appointment with us. We'd be happy to help you and hopefully give you a better quality of life and alleviate some of the symptoms which may be affecting that. So thank you all for your time today. I hope everybody was able to gather a little bit more knowledge, and hopefully this was helpful for everyone.
Wow, thank you, Dr. Hicks. Amazing, as always. We can open up now. If anyone has questions, feel free to, unmute yourself and ask a question of Dr. Hicks, and or use the chat, whichever you prefer, and we'll relay the message to the doctor and get your questions answered. There's a lot of information, I know, so. And while we're waiting for people to think about that, we are, as I said, this is recorded, and this is will be sent out to everyone via a link within probably the next 7 to 10 days, if not sooner. Anyone who registered, and then it'll also be on Eisenhower Health YouTube channel, as well as on our Eisenhower Health website. All right. Well, you have the doctor's information. If you can go, doctor, is it possible to go back one slide? I think, are you able to?
I can't see the questions on my.
No, just your slide.
Oh,
just so
okay.
Oh, there we go.
There you go.
No, I just want to make sure. So if you did have additional questions, or you want to schedule an appointment with the doctor, obviously it's on the screen, but the phone number is 760-773-1840. And this will be sent again with if you registered, which everyone did, we'll send this with a link and the contact information to check in with Dr. Hicks. All right. Well, if there's no questions coming in, give it another second for people to formulate. And if not, any final words from you, Dr. Hicks?
No, I appreciate everybody for coming out. And again, anything we can do to help out, we'd be more than happy to.
Great. Dr. Hicks, thank you so much. And everyone have a safe and enjoyable evening.
Thank you.